Good afternoon. Hi, I'm John Littell, Dr. John Littell, coming to you from Ocala, Florida. It's a Friday afternoon, and so it's been a long week taking care of patients, and I want to let you know that my first priority really ultimately is to God and to my family and to my patients, and yet I feel like I want to spend some time with you, whoever is able to listen to me, to hear a perspective perhaps of a physician who is not owned by any particular agency. Many of you have come to know me through various videos and conferences, and I've been encouraged most recently to start sharing with a wider audience some of what I'm seeing each day in my practice here, not only in Ocala, Florida, but my practice in Kissimmee. Just to help you become more empowered as you go about your day making decisions about your health care and the health care of your family members and loved ones. I have three particular things I want to share with you today that are frustrations of mine that have just come up in the last week and are probably frustrations of yours as patients or even fellow providers. I hate that word provider, sorry. I'm fellow physicians and healers. Okay, that word provider is an insurance concept that makes us feel like we're cogs in a wheel, or just, well, that's what they're making us, little automatons. But that's one of the things that bugs me. So let's start with that. And also at the end, I want to share something that's a very positive note. I believe every time I come and talk to you, just as I would with every appointment I have with a patient, we need to end on a sense of hope. People need more hope in their lives. They need more peace in their lives. And so just worrying about things and complaining about things really doesn't get us anywhere, does it? And but let's talk about a few worries that I hear from my patients each day or that I experience. One of them is with regards to insurance companies. I mean, right now we have this incredible intrusion into the patient-physician relationship by the government, and the government in the way of the insurance companies, whether it's Medicare or you name the company that's out there, United, Aetna, Humana, all of these companies, and I've seen this happen, by the way, from the very beginning of my political involvement, which was really once President Obama got elected, I realized that government-run healthcare was going to exponentially increase beyond what happened in the 1960s with the rollout of the Great Society and the Medicare and Medicaid programs, specifically Medicare, and the rollout of things like the ICD terminology and the CPT terminology that doctors use to be able to quantify what they're doing and get paid for what they're doing. And it already became less about the patient and more about the transaction, the financial transaction that was taking place. That goes back to the 60s with the introduction of these insurance-based programs. But then you see with the Obama care initiatives, doctors were being told to do more things, jump through more hoops. And the quality measures, how they measured the quality of healthcare were being determined not by doctors, not even by nurses, and certainly not by patients, but by bureaucrats in suits in Washington, D.C. I could tell you a lot more about that, but what really totally ticked me off recently is when I had a patient calling me. It wasn't even it was the insurance company calling me and telling me that I needed to adjust patients' medications based on what they had found while visiting the patient's home. And they said it was a house call or a home care. And I called the patient. I said, What's going on? Why are you having home care? Are you stuck at home? He said, no, I'm driving everywhere I want to go. I go everywhere. The insurance company knocked on his door, came into his home, measured his blood pressure, and decided to prescribe a medication for this patient of mine without calling me, without informing me, except to say, hey, if you want to call us and tell us what we did, or find out what we did, call. Well, as though I had time on my hands to just call insurance companies and find out how they want to take care of my patient. So this clearly did not set me off well, and I told that patient never again to allow an insurance company to come into his home to provide health care, because that is not the purpose of healthcare insurance. And you all know that, and I know that. But this is happening everywhere we turn right now. And when I called the insurance company person, I said, what were you doing? The lady told me, well, we're just the link between you and your patient. We're just helping you by being able to go in and see your patients. Well, you're not working for me. You're not one of my employees. You're not a nurse practitioner working for me. You're not even a home health care agency working with me. And I do use home health care agencies, and I recommend home health care agencies. They do God's work for patients who are homebound, recovering. So, no. Number one thing, it does bother me. You can tell. So then number two is the fact that I go to a mandatory conference this past weekend for the state of Florida. To keep my license, I have to go to 3 various talks, each are 2 hours long. One is on domestic violence, fascinating and very troubling topic that we all need to come to grips with. At that talk, the lovely lady who gave it expressed her frustration with doctors who don't take the time to get to know what's really going on with patients who are suffering in their homes from abuse. And that could be wives, it could be husbands, it certainly is children. And she made a comment. It's interesting. In the same morning, I went to 2 talks. The first one was on domestic violence, and she makes a comment before a number of physicians and nurse practitioners that doctors are too concerned with the financial transaction or with the time component. She talked a little bit about money, but she mostly talked about time. She said, well, doctors, after all, time is money, and you only have so much time, and you don't get to ask these questions. And one physician in the back objected to her and said, you just turned off everybody in this room because you're accusing us of not spending time with patients because we're too concerned about money. And, I felt bad for that lady because she was having to defend herself for making a statement which, as I reminded that doctor and every doctor in the room, no, in fact, the medical profession has become about that transaction and less about taking care of the patient. And I even looked at him, I said, look what's happening. Look at what the insurance companies have turned us into. We are told by the people who pay us that we have to check off all these boxes and do all these things, and we're in this urgent care mentality. A lot of people in healthcare come from the urgent care mentality, meaning the when you go to the emergency room or the clinic, the same day clinic, and you come in with a complaint, you address the complaint, you go home. But does anyone ever say, hey, tell me about your home? Tell me, who do you live with? Who do you care for? What does your husband do? Who's got what jobs? What are your children? Are you taking care of grandchildren? Right? Do you have a husband with dementia, etc.? All of these things that are going on just to learn about the patient. Well, no, that doesn't happen routinely. In your own experience, I'm sure it doesn't. And I tell people, when people come to work for me as nurse practitioners or doctors or the medical students who come, I say, the most important thing you do when you first walk in the room is not to address the chief complaint that you've given to the medical assistant. It's to address the social history. Who is the person in front of you? That is the beauty of family medicine for me. It should be the beauty of medicine for every physician. Getting to know the person before you address the chief complaints, because they come in with headaches, and ultimately those headaches are due to something that's very, very difficult to elucidate. All right, the medical assistant is just not going to get into all that. She's just going to write, patients had headaches for 2 weeks, and you find out, which I did just today, that the daughter committed suicide 2 years ago, and they're coming in on the anniversary of their daughter's suicide. All right, this is the stuff, and it takes a long time to get to that sometimes. And so, again, that was one talk, domestic violence, and I corrected that doctor, and I supported that woman who said we don't get to these issues of abuse in the home. But then the next talk was on medical errors. And this is the most amazing thing I wanted to share with you. This is, you just picture this. You've got a woman in her probably 60s from the medical malpractice company talking to doctors about how to prevent medical errors. And her comment to me, I gotta read this because it's you can't believe it. She said that not following the guidelines from, and you can list the agencies, United States Preventive Services Task Force, CDC, NIH, not following guidelines and evidence-based medicine is the root cause of most medical errors and lawsuits. Not following the guidelines. And then she described to the doctors and the nurse practitioners a visit she had made to a physician who, for whatever reason, had a lawsuit, all right? And she goes into the doctor's office, and by the way, lawsuits against doctors, don't get me started. There's so much injustice there that it would take up a whole day. Because only in America can a person sue and have no skin in the game, and then the lawyers who defend me or other doctors say, listen, Dr. Littell, we're going to settle because it costs us more to defend you in court than to settle with Morgan & Morgan or some other lawyer in town. That's what they do. So it's a game they all play. Don't even get me started on lawsuits. But she says that you need to follow guidelines. And then she talks about going to see a doctor who's my age or older, and she and she looks around and she sees, and she looks at all his charts, and she says, in your charts, you're not describing that you're going by the guidelines. You're not following the guidelines. And he looked at her and he says, that's why I became a physician, so I could exercise my independent thinking and make an independent judgment about my patients. I didn't become a physician to follow a bunch of guidelines that, as I said earlier, are put together by people in suits in Washington, D.C. who don't take care of patients, or clinical people who are in research, like somebody we all had to deal with the last 3 years who's never taken care of a patient in his life, telling us how to manage COVID. All right? That's not why we become doctors. So the irony is that same woman giving that talk on how we need to follow guidelines later says, oh, and you also need to get informed consent before you give anybody a medication. Always get informed consent, make sure they know everything about a medication. And she says to me, you'll get a load of this, she says, oh, at my doctors, I'm a terrible patient. They try to give me medication. I tell them I'm not going to take anything unless it's been out for 10 years. And to which I just interrupted her. I said, you are the biggest paradox I have ever listened to. I mean, you, on one hand, you're telling us to follow guidelines like a bunch of robots. On the other hand, you're saying as a patient, you don't want us to prescribe medications that are in the guidelines because you want to make sure they've been out and proven safe and effective for 10 years. So you see what we're dealing with as doctors, and nobody else in the room, really, it seems to me, wanted to make those comments until after I was leaving, and several of the younger physicians came up to me and said, Dr. Littell, thank you for pointing that out. Thank you for pointing that out. It seems to me that sometimes I'm the only one who speaks out on these things in some of these meetings, and of course, as some of you may know, the only one who gets into trouble. So that was the second thing that upset me today, is essentially that I'm at a meeting learning how to be a better doctor, supposedly, for the state of Florida by learning about domestic violence and now how to prevent medical errors. And I'm getting all this drivel about following guidelines would make me a better doctor. And so where we are right now, we're at a point, the third thing that happened today is that, I had a patient come in who is all concerned because her previous doctors have told her that she has to be on medications for osteoporosis and medications for hyperlipidemia, high cholesterol, and medications for thyroid. And when I went through her charts and I looked at her, and she was so healthy, she was in her late 70s, she had no issues whatsoever, medically felt fine. I looked at her, I said, ma'am, I'm so sorry that the medical profession has done a disservice to you. We're treating you as a number. We're looking at the bell curve. The bell curve, all of us got graded, and we're saying, oh, you need to be right here in the middle of the bell curve, or you're not normal, and if you're not normal, you're not healthy. And normalcy is not healthiness. Wellness is not being normal. Wellness is being optimally where you need to be, body, mind, and spirit as God made you. So no, this is what we have done. By following these guidelines, these algorithms, we are turned into robots. And so now, as you've seen, as people are obsessed with these guidelines, we see the damage it's done over years and years. I'm reminded, as I begin to close here, of a physician who was very influential to me. Dr. Herbert Ratner is one of my heroes in medicine. He was a pediatrician in Oak Park, Illinois, a suburb of Chicago, back in the 40s and 50s and 60s. When I heard him speak, he was into his 90s at Catholic Medical Association meetings, and he'd give lectures with a blackboard and chalk. And he was a scholar on Hippocrates, the father of medicine, and he spoke several languages. And this is a collection of his essays. And one, he talks about how the physician cooperates with nature. All right, he reminds us that the word physis, P-H-Y-S-U-S, means nature. And here's a good example. When the physician, without nature, let me start here. Without nature, the physician can accomplish nothing. When the physician sews up an abdomen, his work is finished, but the work of nature has just started. Nature has to heal the wound, bind it together, absorb the stitches. The physician properly collects the fee. This is back in the 1950s before insurance companies. It was just a simple transaction. But let us not forget that nature does a good share of the work. The physician sets the broken bone, but how does the bone get healed? Nature moves in with a wise, comprehensive pharmaceutical plan directed at healing the bone. It brings to the fracture all the chemicals, the raw materials, and the nutrients that are needed for healing. And so he reminds us of a saying that Ben Franklin made, very wise Ben Franklin, that there's a great deal of difference between a good physician and a poor one, but very little difference between a good physician and none at all. And that is a comment that I've never forgotten. I share it with people in many settings. The good physician imitates nature, cooperates with nature, allows nature to do the healing. You all know this out there, but what has happened in current medicine with algorithm-based medicine, protocol-based medicine, evidence-based medicine, is that we're forgetting about nature. And we're also forgetting about our own God-given ability to reason and come up with the right plan for the patient. The last thing that I was going to do, three things that bugged me, but this is maybe an extension of that. I came across this recently. I was looking for it for the last several months. During the height of the COVID pandemic, when physicians were being told they could not treat patients, and patients were dropping like flies with the Delta variant in July, August, and September of 2021. This missive, this guidance went out from one large hospital system in Orlando, Florida. It says treatment guidance for non-hospitalized patients with confirmed or suspected COVID-19. Now keep in mind, this went to every employed physician, and they have hundreds if not thousands in this system. It says here, the following information is served as general guidance to prescribers treating non-hospitalized patients with COVID. There are limited treatment options proven to be effective in the treatment of COVID-19 in non-hospitalized patients. We recommend against the use of the following agents given lack of data, which to them means it wasn't published in a peer-reviewed journal at that time. All right, to support their efficacy in patients with evidence of potential harm, they add. So they're telling the physician, not only is it not supported, but it may harm the patients. And the first thing at the top of their list is corticosteroids, prednisone. Prednisone not being used to treat COVID-19 patients who were hypoxic, who had inflammatory conditions that were never before seen in respiratory patients. I saw a bit of it with some influenza, the H1N1. But this was not a simple bronchitis, as most of you understand by now. This was an inflammatory cascade like none other. We needed anti-inflammatories, and my good friend Dr. Pierre Corey was one of the first to point that out. And it was not long after this that the hospital said, oh, are bad, and they started giving inpatients high-dose corticosteroids. But they're telling, in the early days, actually this is in the middle of the pandemic, in July of 2021, no use of prednisone, no use of hydroxychloroquine, no use of ivermectin, no use of azithromycin, a Z-Pak, which we all know, and we've been given. So I was director of soldier care when azithromycin first rolled out in the early 90s in Augusta, Georgia at Fort Gordon. We knew then that the macrolide group of antibiotics, which was started with erythromycin and then azithromycin, had miraculous recovery rates in the troops in the barracks who were getting bronchitis, even if it wasn't bacterial. We knew that, and it was marketed for that. And yet when COVID happens, we're told not to use it. And not only are we told not to use that, but we're told not to use another even more amazing macrolide antibiotic, which was ivermectin, as always should have been called ivermycin. It's in the same category as azithromycin, and yet it did so much more, as we saw when we added it to the azithromycin or doxycycline. So I'm just reminding you, this is an example of what happens when doctors follow guidance and guidelines and algorithms. They checked out what they knew about the treatment of a simple condition like bronchitis. They couldn't extrapolate that to the treatment of COVID-19 bronchitis, which then became pneumonia, which then became death for those who ended up in the hospital. Take a deep breath. You know, I do that. I take a deep breath when I'm with patients often because I'm hearing stories that honestly are, I shouldn't have to hear every day in my office. And yet I'm privileged to hear those stories. I tell my medical students, the privilege of being a family physician is you get to learn about patients by hearing their stories. So let me tell you a story that I really found uplifting. A young lady, everyone's young to me anymore, I'm getting to be old, aren't I? But a woman I've taken care of for many years, who I first diagnosed with ovarian cancer about 15 years ago actually, and had a miraculous cure thanks to exceptional care by traditional medicine, oncological surgeons, who were able to clean every bit of cancer out of her. And it was metastatic ovarian cancer, you can imagine. And she was sitting before me in my office and sharing with me some struggles she's having with a son of hers who is addicted to drugs, and then other issues. But she said her therapy, and she just spontaneously shared this with me, her therapy is painting. And she felt like, even though no one else seems to say how great a painter is, she feels so much fulfillment in her paintings. And she took out her phone and showed me pictures of her artwork, and it was all beautiful pictures of nature and scenery that she'd seen, a beautiful tree, a scene in the forest. And what was amazing to me is that very morning I had read a poem, and I always enjoyed poetry, and the poem written by Rudyard Kipling, great poet from England. You hope you know about Rudyard Kipling. He wrote the Jungle Book. Many people know is a Disney movie, but his poetry is just unsurpassable. And so he wrote a great poem that I in fact shared with her, because everything she told me about her painting was reflected in this poem that I had read for the first time that morning. So go figure. How does God work? And the name of the poem is When Earth's Last Picture is Painted. When Earth's last picture is painted and the tubes are twisted and dried, when the oldest colors have faded and the youngest critic has died, we shall rest, and faith we shall need it. Lie down for an eon or two, till the master of all good workmen shall put us to work anew. And those that were good shall be happy, they shall sit in golden chairs. They shall splash at a 10-league canvas with brushes of comet's hair. They shall find real saints to draw from, Magdalene, Peter, and Paul. They shall work for an age at a sitting and never be tired at all. And only the Master shall praise us, and only the Master shall blame. And no one will work for the money, and no one will work for the fame, but each for the joy of the working, and each in his separate star shall draw the thing as he sees it for the God of things as they are. And that's what I shared with her, and that's what I'm happy to share with you, that the work that we do is not for the fame and not for the profit. It's for the glory of God and for the good of all his creation, and that is why I'm privileged to have the vocation of family medicine and to be with you today. And thank you. God bless you. Hope to see you soon. Bye.